Hello, Scott Malinowski here, and we're going to be talking about the nutrition support for Skills Lab, and this is part one in the series for specialized nutrition support. So first of all, let's talk about some terminologies. You'll hear many different terms used referring to specialized nutrition support, TPN, TNA, HyperAL. And so on this page you can see a lot of those abbreviations, and a lot of them are used interchangeably, sometimes inappropriately, but commonplace practice we say a lot of things. So SNS is what I call specialized nutrition support, and that really refers to the parenteral or enteral nutrition specifically. And then sometimes we use the terms TPN, HyperAL. Of course, TPN stands for total parenteral nutrition. So total inferring that they're getting all their nutrition provided intravenously from that TPN bag. But sometimes that's not the case. A lot of times they'll get a little bit of supplemental nutrition either from oral intake, from tube feedings. So it's sort of a misnomer. PN, parenteral nutrition solution, is probably a more proper term if you're talking about that bag of nutrition that we commonly refer to as a TPN bag. But again, a lot of people will use them interchangeably, and it's not always technically correct, but as long as you understand what we're talking about. TNA on the second line there refers to a total nutrient admixture. Sometimes we call that a 3-in-1 TPN as opposed to a 2-in-1 TPN. The total nutrient admixture 3-in-1 TPNs are the ones that have the lipids in them as well as the dextrose and the protein, and they're kind of a milky white looking solution, so you can't see through it. If it's a 2-in-1 TPN, then it's kind of has a yellowish tint to it. That's the vitamins that are added to it as an additive, and but technically you can kind of see through it. So hyperalimentation fluid, HAF, HyperAL, these are all old terms. And tube feed, that can refer to nasoenteric feedings, nasogastric, even the NG tube, though we try not to feed straight into the stomach. We like to have a long tube that goes into the small bowel, so hence the term nasoenteric. Or sometimes it doesn't even go through the nose, the tube goes through the mouth. We call that an orogastric or oroenteric feeding tube. You'll see the term Dobhoff tube, DHT, and Dobhoff is actually a brand name of a feeding tube, sort of like Kleenex or Xerox. We use those to refer to a certain product, but technically it's a brand name. So again, you'll hear people use the term Dobhoff tube for feeding. That's okay, it's just technically a brand name. Sometimes talk about PEG tubes, percutaneously placed endoscopic gastric feeding tubes, or sometimes this even goes into the jejunum, jejunostomy tubes. So these are a lot of terms and abbreviations that you'll see when we're talking about specialized nutrition support. Okay, so there's lots of types of nutrition support. Again, specialized nutrition support would be things that are enteral and parenteral, enterally and parenterally administered nutrition. The other kinds would be the things we're more familiar with, like oral diets. Those are subdivided down into clear liquid diet, full liquids, regular diet, which is what we usually eat. So EN, the abbreviation for enteral nutrition, PN for parenteral. Parenteral nutrition is then subdivided down further into central parenteral nutrition and peripheral parenteral nutrition. And the difference there is talking about the vein that it goes into. So for example, CPN is TPN that's going into a central vein, usually the vena cava, sometimes a femoral vein, and peripheral would be one that goes into the a smaller peripheral vein, like in the arm or the top of the hand, for example. And another important concept to remember is that the oral route, or even using the gut through the enteral route, is a much more normal and physiologic method for our bodies to process nutrients, food. So by going to the intravenous route with the parenteral formulations, that's a very different. It's not how our bodies were meant to process food. So there are some inherent risks involved with doing so. Enteral nutrition is also inherently safer because you're not going straight through the body's main barrier defensive barrier, that being the skin, and administered something IV. So again, it's using the normal, more physiologic route, the GI tract, to provide foods. And so certain goals that we have for specialized nutrition support are primarily revolve around these three things here. Try to get the patient 100% of their estimated nutritional needs and avoid complications in the process of doing so. And anytime you can switch or facilitate transition to from intravenous to using somebody's oral or enteral tract, that's always best. Like for the reasons I mentioned earlier, with the risks and complications associated with intravenous or parenteral nutrition support. And so we talk about 100% of nutritional needs. We're talking about several different things there. Kilocalories, proteins, vitamins, as well as fluid can be considered sort of a nutritional need. It's essential to have a fluid vehicle or medium to administer and for the body to process nutrients. So you should know by now, TPN isn't just for everybody. There are risks. It's very expensive. It's not something to be taken or administered lightly to just anybody who feels like they aren't able to eat today, but really need to be selective and identify who's an appropriate candidate for TPN, for any kind of specialized nutrition support for that matter. But specifically for parenteral nutrition, this page gives you a few categories or criteria for who would be a likely candidate. For example, patients who cannot, will not, or should not eat adequately, in other words, adequately to maintain their nutritional status. Somebody's already malnourished, or somebody who hasn't had adequate intake for the past 1 to 2 weeks, or even if you predict they won't have adequate intake for the next 1 to 2 weeks. Somebody with high degree of metabolic stress, and this could be somebody who's experienced burns or someone in the intensive care unit. Anybody who's pretty sick, essentially, and it's pretty obvious once you look at their diagnosis or look at the patient. And also somebody who's got loss of body stores. Again, we have malnourished up here, but it's not always obvious that people have loss of body stores. So it's not exactly the same thing. So generally speaking, who's a candidate for TPN? Probably somebody who has at least 2, definitely 3 or 4 of these items listed here. Would be a strong candidate for parenteral nutrition. So in summary, there's a few general concepts that you should always keep in mind as you're considering specialized nutrition support for a patient when you're about to recommend it, things to think about as you implement this therapy. Again, who's a candidate for TPN? Well, not everybody. Be selective and think about the criteria on the previous slide. And when you're giving it, you should always be thinking of, can I use the patient's GI tract, their gut? Because the gut is a very good organ and it works very well, so we need to optimize its use. And then needs. This is important. If you decide that you're going to go with either enteral or parenteral nutrition, it's important to individualize it to each patient based on their characteristics, height, weight, condition, organ dysfunction. The one thing you don't want to do is overfeed. Don't overfeed. We'll talk about that more in a little bit, but there are risks associated with that. And the risks associated with overfeeding are much worse than those associated with underfeeding. So you want to try to hit the target and hit the optimal amount of calories and protein. We do not want to give more than the patient needs. It's dangerous. Then when starting TPN, remember, start low, go slow. It's not a medical emergency, so you can take your time with it. And most importantly, you want to make sure the patient tolerates what you're giving them. So start out at half or so of what you think they need as a goal amount and kind of take it slowly from there over the next couple days even. And above all, do no harm, so we monitor closely. Again, there are components to TPN that are dangerous and can be problematic, so we want to monitor closely for those things. We'll talk more about that in a little while. We don't just start TPN and then forget about the patient for the next week or so. We have to check them literally every day, for at least for first couple weeks until they either are off TPN or go home on TPN. Then transition. As soon as we start TPN on someone, we're always thinking, how can I get them off TPN? Can I use their gut? Can I let them eat by mouth? Do I need to try to place a feeding tube to use the GI tract? Okay, let's talk now about caloric requirements. So this is the start of getting into calculating a TPN and estimating someone's nutritional needs. So the first question, after you've decided that they're a candidate for specialized nutrition support, you should be thinking, how many kcals should I feed this patient? And again, should be individualized, so tailored to that patient's specific body size, their age, gender, medical condition, so on and so forth. And why does this matter? Well, again, we mentioned just a minute ago, if you underfeed somebody for too long, that's not good because that results in malnutrition anyway. Appropriate feeding is great. That's our target. That's what we're shooting for. And overfeeding, when you're giving them too much nutrition, their body just can't process or handle all of that nutrition, leads to a lot of bad things. So again, overfeeding is much worse than underfeeding, and it happens fast if you do, so we certainly want to avoid that above everything else. So look at this graph here. Positive outcomes, to increase those, a certain amount of kcals per day, starting at a very low amount to a very high amount. Somewhere in between low and high is the patient's target or optimal dose of kilocalories per day. And when you're there, you should associate it with the most positive outcomes. If you give too low of a calorie underfeeding, that leads to things like malnutrition, poor response to injury, loss of lean mass. And the flip side of that, if you give too much, overfeeding, you can have things like fatty liver infiltration, also known as hepatic steatosis, where the body can't process the nutrients you provide and burn it for energy, but it instead stores it, and it does that as fat, and it does it in the liver, and that impairs the liver's function. Not a good thing. And in the process of doing that, it produces a lot of carbon dioxide, and you have to exhale that. So if you already have lung problems or on a ventilator, it makes for a lot of respiratory issues. And on top of all that, of course, giving too much carbohydrate when the body can't handle it, and the pancreas's production of insulin can't keep up with the amount you're giving, it results in hyperglycemia, which has its own whole hosts of problems associated with that. So again, the idea is to hit the optimal target range of the patient's optimal or adequate nutrition. You don't want to give too little, don't want to give too much. It's important to be familiar with the consequences of doing too little or too much. So we know that determining the patient's optimal energy requirements or estimated nutritional needs is important. And so how do we go about doing that? Well, there's basically three ways that are probably the most common methods used. Indirect calorimetry, the first one, is a technique that uses a computer, some respiratory gases, and some other mechanical equipment that you actually attach to the patient, and it monitors their breathing, and it monitors how much oxygen they consume, how much carbon dioxide they produce, and it does that for about 20 minutes or so, and then we'll kick out a number, and that'll give you a resting energy expenditure, which would be something for a typical person, somewhere around maybe 17 or 1800 kilocalories per day. So it gives you a number in terms of a daily requirement, or what it gives you is the amount of calories that it thinks the patient is burning. So if they're burning 1800 calories, what we try to do is replace that amount with the same amount. And so if they're burning 1800 calories, then we provide them 1800 calories via nutrition support to try to meet that their energy demands, and have a nice balance of energy burning and input. Okay, so I'm just about at the 15-minute mark, which is the limit for these videos. So we're going to continue talking about the Harris-Benedict equation in session number 2 of the series.